Good morning, friends. I am Dr. Shoaib Padaria from Mumbai, India. First of all, thank you very much to the Canadian Society of Phlebology and Dr. Pauline for inviting me to participate. The topic of discussion today is risk assessment and prophylaxis for venous thromboembolism in pregnancy and postpartum period. We all know that VTE, which combines deep vein thrombosis and pulmonary embolism, is a very common condition. VTE is the third leading cardiovascular killer after heart attack and stroke, and VTE causes more people to die annually than breast cancer and AIDS combined. Why does VTE occur during pregnancy? Pregnancy is a prothrombotic state, and various pathophysiological changes lead to one, an increase of procoagulant factors, secondly, various physical changes which lead to increased stasis, and finally, the additional contribution in some cases of inherited and acquired thrombophilias. When does VTE occur during pregnancy? A meta-analysis has shown that 2/3 of cases of deep vein thrombosis occur antepartum, distributed equally throughout all 3 trimesters. In contrast, 43 to 60% of pregnancy-related pulmonary embolism occurs 4 to 6 weeks postpartum. What is the duration of the postpartum risk? The prothrombotic changes which are associated with pregnancy do not revert completely to normal until several weeks after delivery, and clinical data suggest that increased risk of VTE persists for up to 6 weeks postpartum. Pregnant women have a 4 to 5 times increased risk of symptomatic venous thromboembolism. The overall estimated incidence is 1 to 2 per 1,000 pregnancies, and 85% of cases of DVT are in the left lower extremity. What is the rationale for thromboprophylaxis in pregnancy? This is because VTE is a major cause of maternal mortality. We know that thrombosis and thromboembolism are responsible for 1 in 100,000 maternity mortalities, and this is a high incidence. Especially in developing countries like India, thromboembolism can be a leading direct cause of death, and thromboembolism contributes to almost 25% of these cases. In addition to that, there's a changing profile of pregnant females, and this leads to an increased risk of venous thromboembolism. These patients are older, they are heavier, we find more smokers, history of previous cesarean section, IVF pregnancies, and various comorbid medical conditions. Now, in order to prevent VTE, we have to give anticoagulation. In most cases, the risk of anticoagulation far outweighs the benefit. We must, however, know that the risk of maternal bleeding with anticoagulation is about 2%. Not only that, anticoagulation is inconvenient, painful, and difficult to administer. And therefore, we must identify those patients who have specific risk factors likely to lead to DVT or pulmonary embolism. When should we perform risk factor assessment? At any point of time, preferably during early pregnancy or in the pre-pregnancy state, on admission of the patient to hospital for any reason, or during intrapartum or immediately postpartum period. So what are the risk factors for thrombosis in pregnancy? There are 3 basic groups. One is the various physiological process of pregnancy. Secondly, inherited coagulopathies. And thirdly, the various obstetric and acquired risk factors. The physiological changes which occur in pregnancy lead to various changes in coagulation factors. This increased levels of procoagulant factors, decreased serum levels of protein C, protein S, and a decreased fibrinolytic state, all of which contribute to increased thrombosis during pregnancy. There are, of course, the inherited coagulopathies. Of note, the most important one is factor V latent mutation heterozygote. The prevalence of this is 2.7 and the odd ratio is 9. There are various other inherited coagulopathies, but their prevalence is quite low in the general population. Now, these inherited coagulopathies are thrombophilia. are present in almost 20 to 50% of women who experience VTE during pregnancy. And are three such groups of patients. One is those pregnant women with thrombophilia and history of previous VTE, pregnant women with thrombophilia but no previous VTE but a family history of VTE, and lastly pregnant women with thrombophilia and no previous VTE and no family history. These three groups are important because the risk factor stratification is also different. There are also various obstetric risk factors. A large number of these obstetric risk factors can also contribute to increased risk of thrombosis during pregnancy. High body mass index and immobilization is also an important risk factor. We know that antepartum immobilization, which is defined as strict bed rest for at least 1 week, was the strongest risk factor for both ante and postpartum VTE. This effect of immobilization is modified further by body mass index, which has a multiplicative effect. And obesity is a well-known risk factor for VTE both in the general population and during pregnancy. Why is stratification of risk of VTE necessary? It's important because it helps to determine in which patients to initiate thromboprophylaxis and also when to initiate it. So let us consider various obstetric risk factors. All those in yellow are the low risk factors and they're given 1 point. The one in brown, which is cesarean section and labor, is an intermediate risk factor and given a point score of 2. The various pre-existing risk factors, of which history of previous VTE is a high risk factor given 4 points. Previous VTE provoked by major surgery, known high risk thrombophilia, and various medical comorbidities are all intermediate risk factors given 3 points, and various other low risk factors. And then there are various transient risk factors. The ovarian hyperstimulation syndrome is a high risk factor with 4 points. Any surgical procedure in pregnancy or puerperium except immediate repair of the perineum are given 3 points, and also hyperemesis is given 3 points. Now when you consider all these risk factors together, all those which fall into the high risk category have to compulsorily be given antenatal prophylaxis with low molecular weight heparin to be continued for at least 6 weeks postpartum. Those with intermediate risk factors should be strongly advised antenatal prophylaxis and also to be continued in the postpartum period. When you have low risk factors, then if you have 4 or greater risk factors, thromboprophylaxis should be given throughout pregnancy and for 6 weeks postpartum. If you have 3 risk factors, start the prophylaxis after 28 weeks of pregnancy, again continue for 6 weeks postpartum. And if you have 2 risk factors, you must give prophylaxis for a postpartum 10 days period. Now, which anticoagulant drugs to use for thromboprophylaxis? Vitamin K antagonists like warfarin are to be avoided. We all know that it crosses the placenta, it is teratogenic, fetal anticoagulation can result in intracranial hemorrhage and therefore should be considered for women at high risk of thrombosis, such as those with a mechanical heart valve. Low molecular weight heparin is the preferred drug of choice. Once or twice daily regimen should be used. A weight-based regimen is preferred, and monitoring of factor anti-10A is not routinely required. Now, there are various advantages of low molecular weight heparin as compared to unfractionated heparin. It has a better safety profile both for the fetus and the mother, potentially reduced risk of bleeding. They are not associated with an increased risk of severe peripartum bleeding, and unlike unfractionated heparin, does not decrease the bone density in patients. Also, there is no history, no consequence of heparin intolerance in these patients. How do you give low molecular weight heparin? The commonest drug which is used is enoxaparin, and you normally give it at 1 milligram per kilogram every 12 hours. Other drugs such as dalteparin and tinzaparin can also be used. You can also follow a dose chart depending on your weight, and you can titrate the dose of low molecular weight heparin accordingly. Unfractionated heparin is preferred over low molecular weight heparin in peripartum period when there is an increased risk of hemorrhage. We know that the effect is shorter and can be reversed rapidly. It is of course much cheaper than low molecular weight heparin and is preferred in patients with severe renal insufficiency. However, unfractionated heparin can cause heparin-induced thrombocytopenia, can cause bone loss, and needs regular monitoring. What is the dose of unfractionated heparin during pregnancy? In the first trimester, it's 5,000 international units subcutaneously 12 hourly. In the second trimester, it's advised to give 7,500 international units 12 hourly. And in the third trimester, 10,000 units 12 hourly is to be given, and titrate the APTT to 1.5 to 2.5 times the control. Anti-embolism stockings and pneumatic compression devices have also been advised, especially in those who are at moderate to higher risk of VTE during pregnancy. What about thromboprophylaxis during labor and delivery? Some do's and don'ts. Thromboprophylaxis to be interrupted if 1. There is presence of vaginal bleeding. 2. At the onset of labor pains. If you plan an effective cesarean section, elective cesarean section, then if the patient is on low molecular weight heparin, you can do that 12 hours after prophylactic dose or 24 hours if the patient is on a therapeutic dose. If you're using unfractionated heparin, then 6 hours after prophylactic dose and 12 hours after a therapeutic dose. If you have an epidural catheter, you should remove that 12 hours after the last dose of whether you've taken low molecular weight heparin or unfractionated heparin. When should you restart thromboprophylaxis postnatally? If it's a vaginal delivery, start at 6 to 12 hours later if there is no postpartum hemorrhage and if there is no epidural catheter. If it's a cesarean section, after 12 to 24 hours. And resumption in patients receiving antenatal thromboprophylaxis can be done earlier, 4 to 6 hours after vaginal delivery and 6 to 12 hours after cesarean section in the absence of significant bleeding. How long to continue thromboprophylaxis after delivery? Depending on various risk factors, again whether it's high risk, intermediate risk or low risk. In high risk patients, continue for at least 6 weeks after delivery. In intermediate risk patients, for 10 days. And if you have additional risk factors, extend for 6 weeks or till the factors persist. So to conclude, friends, all women should undergo risk assessment for venous thromboembolism in early pregnancy, preferably in pre-pregnancy. Reassessment on any antenatal admission or during delivery postpartum period. Both low molecular weight heparin and unfractionated heparin can be used for thromboprophylaxis. Low molecular weight heparin is effective, easy to administer, and does not require any monitoring. Any women with 4 or greater current risk factors should be offered prophylactic low molecular weight heparin throughout the antenatal period and for 6 weeks postpartum period. Any women with 3 current risk factors should be offered prophylactic low molecular weight heparin for 28 weeks gestation and for 6 weeks postnatal period. And anyone with 2 current risk factors should be offered prophylactic low molecular weight heparin for at least 10 days postpartum. Short-term thromboprophylaxis should be considered for pregnant women admitted with hyperemesis gravidarum or ovarian hyperstimulation syndrome. Risk of VTE should be discussed with all women at risk. Necessary precautions should be observed during delivery to avoid complications, and thromboprophylaxis can be started after 6 to 12 hours after vaginal delivery and 12 to 24 hours after cesarean section delivery. Thank you very much for your attention.